Good evening. It's a pleasure to welcome you to today's ESDS webinar with an Oxford-style debate on surgical volume and outcome. Surgical volume and outcome has been shown in a variety of thoracic surgical diseases to be of relevance, and certainly one of the best characterized are lung transplantation and lung cancer. So it is a pleasure today to have a really excellent faculty talking on these two topics. First of all, we will deal with the issue of lung transplantation, where Alessandro Bertani, our ESDS Director of Education, will talk about small is beautiful, and will be followed by Marcel Cypel, Surgical Director of the Toronto Lung Transplant Program, which is the largest lung transplant program in the world. Size matters. And then on the topic of lung cancer, we will have Hake Winter from Heidelberg to talk about the European perspective and recent issues on volume in lung cancer surgery. And thereafter, we'll have Moishe Liberman from Montreal to tell us about the North American perspective. So, Alessandro, the stage is yours, and we're very much looking forward to your presentation. As always, for the audience, please, if you have any questions or issues, put them in the chat or in the Q&A tool, and we will have a discussion at the end of the presentations.
Thank you very much, Clemens, for the invitation, and thank you also to the Society for giving me the opportunity to present on this very interesting topic. And I do not have financial disclosures related to this presentation, but as you can imagine, I have a disclosure about my program, and I do run a small program. I've been running this for 20 years, almost less than 20 transplants per year, and a surgical team of 5 surgeons. And so let's start from a widely accepted statement that large volume lung transplant program will achieve better results than a small one. And this concept can be supported by many principles. Obviously, common sense, number one, published data. There's a lot of published data about this. Analogy with other surgical procedures outcome, and also the tendency of a healthcare system to favor centralization of the care of complex patients. And this is just an example. This a young paper from WashU looking at over 10,000 patients, at 71 patients after lung transplantation. They're looking at 1 in 5 year survivals with a very elegant statistical model, and they find this non-linear relationship between volumes and outcomes, and the sweet spot between pros and benefits in terms of size seems to be 33 cases per year. And as you can see, 23 centers, so about a third of them, reached the volume threshold for the good outcome proportion. And so based on this data, very up-to-date and clear data, should we just accept that high volumes centers have good outcomes and low volume centers have bad outcomes? I think there is a little bit more than this, and I think what we should really look at is do low volume centers can they have good outcomes, and actually can high volume centers sometimes have bad outcomes?
Yes, I hear you.
And to look at all these points and try to answer, let's try to review.
System. Did you receive it?
Yeah, I clicked it and it keeps giving me a hard time getting in. Do you hear me now?
I think, guys, we're hearing you over the presentation. I'm sorry.
Yeah, you're inside.
Okay, thank you very much. So let's take a look at this 4 papers very quickly. This is one of the most cited papers on the topic from Weiss at Johns Hopkins. They do pretty much the same effort. They take a look at volumes. High volume is defined as more than 20 per year. They look at the 30-day, 1 year, and 5 year mortality. And what is interesting is the over predicted value of the model, what is called the C statistics, is kind of low. And also they see that many centers less than 20 transplants per year do well. And this is something that points out that the way you look at this data is somehow very tricky and not always straightforward. And there's another ton of papers. This is looking at cost and ICU stay, readmission rate, and this paper displays better results for high volume centers, but there are always words of caution. For example, this paper about cost is stating that when you reach high complexity, then the cost-volume relationships tends to decrease. So the more complex, the more small centers can get good at doing transplants. And also, excessive high volume may need unavailable resources. So we can also come down to this other paper showing that 1 year mortality, even with a very good and fancy statistical system, is sometimes not a reliable indicator of lung transplant center performance. And in this case, these authors from Ann Arbor show that actually 5 year survival seems to display better the outcomes and the relationship between outcomes and volumes. And one last paper, again, very high number of patients that the authors looked at. As you can see here, after their evaluation of the relationship between volumes and outcome, they state that probably other factors beyond the mere volume have an influence on survival. And volume may not be a perfect surrogate for results. And many low volume centers do have excellent survival rates. And whereas some high volume centers may not have excellent results. So in summary, metrics of lung transplantation based on volumes may not be completely reliable. Outcomes may be good in low volume centers. Complexity of the case mix may play an important role, and cautious interpretation of the results from small centers is really crucial, and the bias of chance is very high. And again, survival rates alone can have different interpretation based on statistical methods. So what should I choose for my vacation? Should I choose a big and famous resort and Caesar Palace, or should I go to a little tiny boutique hotel on the front of the beach? Well, this joke came up from a colleague who visited our institution and designed it sort of as a boutique institution. And I think this gives the opportunity to look into a low volume program and see what happens. So as I mentioned in the beginning, we have a small program. We've been working for about 20 years. So we performed more than 250 transplants, mostly double, 6% pediatrics, 7% low bars, 16% after ECMO bridge, a number of combined transplants, and about a fourth of the patients age more than 60. And we used EVLP. The majority are IPFs. The question is, can complexity be achieved? Yes, a small center can achieve a relatively complex case mixed. And number two, can you have good survival figures? Well, yes, actually, there is this national governmental audit in Italy looking at almost 20 years of lung transplant activity in Italy. And actually, our small center is the best performer, both at 1 and 5 year survival. So that's good news. And can high expertise be obtained in a small center? Well, this really depends on the local hospital environment. And again, just to quote our example, we are a University of Pittsburgh facility in Italy, and we're completely dedicated to organ transplantation. And so this makes us a very small but very high complexity place. Number three, can you lead and innovate as a small center? Well, we tried to, and we sometimes achieved little results, but that could be completed because of the complete control that you can take over the patient, and sort of a personalized approach to each and every case. And for example, in 2008, we performed first case of lung transplantation in an HIV positive patient in the world. And this is because we were able to build a complex immunological and infectious disease management. And now this case opened up a change in the clinical guidelines. Another example, we have been using a very liberal policy of using donors with multi-resistant drug colonization. And this is because in our small setting, we were able to set up a very quick and rapid communication system between donor and recipient setting in order to make sure that any kind of bug is viewed and sorted very rapidly, and a very quick therapy is established in order to prevent complication. And the same thing we just recently did with the prevention and treatment of HHV8. This is a virus infection that is endemic in our region, and we just published this innovative protocol on the screening and surveillance of HHV positive patients and in patients who develop a Kaposi sarcoma. Can you actually teach in a small institution? Well, you can do that. We have developed our own training system. We do our annual, biannual symposium with hands-on training, and well, we have a very young team, actually all-female team, performing individually, independently lung transplantation. And last but not least, can you be cost-effective? Well, just to quote the case of our center, before our center was established, the region was spending more than 20 million euros per year to send patients in other regions and other countries to provide for transplant services. So yes, we can actually be cost-effective. So in summary, it's probably not all related to volume itself. And I think the point gets down to quality of care. And this nice paper from the New England Journal of Medicine touched the issues of volumes and outcomes, and which is to be measured to assure quality. And both of these systems and outcome measures carry bias. So the point is to focus on processes of care, and meaning multidisciplinarity, nursing staff, protocol, clinical pathways, electronic medical records, et cetera, and these are all ways to handle complexity. If you are able to handle complexity, then you can achieve good results. And in the end, I think healthcare quality stands not only in the presence of a high volume, high numbers, but with the combination of high volumes and high complexity. So in conclusion, number one, size matters, no doubt about that. Small can be beautiful, in my opinion, but it's obviously more demanding. Volume plus complexity and plus adequate processes of care really achieve the best healthcare quality. And we must always don't forget about potential downsides of a big program, such as pushing too much, select worst cases, logistic issues. And we should not forget about the potential benefits of being small. And we have seen examples of personalized approach, a fully comprehensive and dedicated team, better logistics, etc. And second conclusion, what is the purpose of measuring the relationship between volumes and outcomes? If the purpose is to regionalize and centralize lung transplant centers, then I think we should be very careful, because the metrics to take this decision still need a lot of work. And these metrics should be focused on measuring quality of care rather than just volume and survival figures. And I'm done with this, and thank you very much for your attention.
Yeah, thank you, Alessandro, for a very nice overview of the boutique approach to lung transplantation. And now we're interested to hear Marcel Cypel's presentation on size matters.
Okay, can you hear me and see the slides?
Yes, working perfectly fine.
Okay, yeah. Thanks for the invitation. I'm very casual here. When Clemens invited me in June last year, I didn't realize I was going to be on vacation on January 13. So I apologize for not being in my office or in my scrubs. Um, I do, just as a disclosure, I do prefer the boutique hotel for sure than the big ones, but I prefer a large lung transplant program in that regard. So I think you can have sometimes best of both worlds. This is just some of disclosures I have. So I think you know. In the previous presentation, most of the data was there, so I'll try not to show too much data here, but provide maybe a few insights. So this is the lung transplant program in Toronto, and we have done over 3,300 transplants to date. And over the last couple of years, we are consistently doing more than 200 transplants a year. And as you can see here, there was over time a significant correlation. As we increased volumes, also our mortality has decreased, and currently it's in a range of 1 to 2% in hospital mortality. And this, of course, includes the transplant of more complex patients and also more extended criteria donors. Let me just pass here. And, in North America, there is the SRTR, which basically it captures all the data from all the transplant centers. Canada is not part of it, but all these blue dots are American centers, and then the green dot is our center. And it basically shows that, even doing a much larger number of transplants than other centers in the continent, we're still being able to keep a 1-year survival in very good stand. So in North America today, basically you can't have any less than 88% 1-year survival in your lung transplant center. Otherwise, you're going to be really an exception, and then there is a risk of even closing your center by the regulatory agency. So there is a big look into 1-year outcomes, and I do agree that 1-year outcomes may not be exactly the best outcome to look for quality, but looking at short-term and long-term outcomes, they disclose a few of the problems of the transplants in different levels. And of course, the goals of transplantation at the end of the day is that we have enough organs for everyone, for equitable access and better recipient outcomes. And I want to point this out, and I'm going to mention my last slide too, is that we can't look at the program just based on the post-transplant outcomes, because you can control that depending on who you list. And also which donors you select. And by doing that, you may have excellent outcomes, but when you look at your overall end-stage lung disease population, they are not being necessarily well served. Now, what does the data show? Most of the studies are old in that regard. A few of them are more recent, but when you go back 10 years ago, and separating low volume, medium volume, or high volume, which at that point was considered 35 transplants a year. I don't think that would be a good stratification right now, but it was very clear that at that point that the high volume centers would do better. And the main thing is again, I agree that small centers can also have excellent outcomes. But when you do less transplants, the variability between the centers is much higher than if you take a cohort of high volume centers. And what also very interesting here, and again, this is US data, 70% pretty much of the centers were low volume centers, like, they do less than 20 lung transplants a month. And that speaks for the potential advantages of centralization. Canada is a very centralized medicine, not only in transplant, but even if you look at, for example, thoracic surgery, there is a big deal of centralization, which have really improved outcomes for patients. Right now in Canada, we have only 4 lung transplant centers, and all of them do more than 70 lung transplants a year. So that really has helped a lot to keep quite good outcomes. Now, when you look at the impact of center volume on survival, again, 10,000 cases here, you can clearly see that 30-day mortality, there is a more steep curve in that correlation. When you look at 1-year outcome, that curve is not as steep anymore, but still there is a correlation there. And again, when you look at 30-day, 1 year, or 5-year survival, you can see, a clear difference between the higher quartile centers compared to the lower quartile centers in terms of these outcomes. This is another study, again, showing that center volume, you can see there is an intersect there, but basically, donor age, recipient creatinine, and recipient age, they basically all correlate with worse outcomes, but center volume is the only one here that actually correlated with improved outcomes for survival. And when you look at the adjusted outcomes of 61 of these centers, as you can see, in the hazard ratio here, as you go high in the number of transplants, the hazard ratio becomes more negative, which means better outcomes. Now, I found this study very interesting because we also have very clear data on this, for example, post esophagectomy. So what happens is, in this study, they look at post-operative complications and their impact on lung transplant survival. And, and these are graphs that show, high volume centers versus low volume centers. If they develop, let's say, renal failure, stroke, arrhythmias, rejection, infections, and so on, how is the outcomes of the patients after they develop those complications, right? And then you can see clearly here that, again, sorry for the graphs are a bit small, but the ability to rescue patients from complications is one of the major advantage of the high volume centers. And again, this has been shown over and over in oncology surgery, especially for esophagectomy patients, where you don't see necessarily a decreased number of complications, but when they do occur, you're much more likely to rescue those patients. I think that's an important concept. And this is the most recent paper, which shows, again, the intersect seems to be around 30 transplants. This is very similar to data on, when you had a lot of publications on ECMO for COVID, also, around 30 to 40 cases a year was kind of the cutoff that showed, better outcomes. And when you go under those numbers, you have so much variability on those centers that when you put all together, you do have a higher hazard ratio there. Now, I also want to mention, the importance of high volume for introduction of new technology as well. And I just want to again give an example of the ex vivo lung perfusion. We, as you probably know, we're a very high volume EVLP, and basically when you look at outcomes after EVLP in our center, they're very good, but also very importantly, we bring very extended criteria donors, and we turn about 65 to 70% of those into transplantation. And one of the major problems during the adoption of EVLP was that the centers that were doing like one case a month, they were doing like 10 EVLPs, and they were transplanting 2 lungs out of 10. And basically that becomes financially not sustainable for the hospital. And so that's, I think, when you add some expensive technology, I think the volume really helps you a lot. Right, just to give an example, right now we have 3 organ perfusion specialists in our hospital, and one of them have done over 1,000 EVLPs himself. So, when this guy calls me at 4 o'clock in the morning and say the lung is good to go, I don't need to look at anything. I just say, okay, well, let's start the transplant at 8 o'clock. And I think that makes a huge difference in the adoption of this technology. And I think also the high volume centers allow you to push more the limits, because any event that you have is not going to have such a big impact in your overall statistics. And here's just an example of a quite extended criteria donor declined by all centers in the United States. And then we went and took this lung. And in fact, we actually didn't, this is just a CT scan. And in fact, after we evaluated these lungs, we took them directly to transplantation without the use of EVLP because they looked actually quite nice. But we wouldn't have gone to this donor center without having EVLP as a backup, and the recipient did quite well. Now, I'd like to say that because the centralization of lung transplant is perhaps important, but I think more important is the centralization of organ donor management. And I think this is, again, how things are evolving in North America. I think in Europe, I know in the UK and also in the Scandinavian, they're looking at those models as well. But having a centralized area for organ ex vivo treatment and assessment makes a big difference. And this concept was first released by our group in 2011, when we opened the first organ repair center to send lungs back to the US. And then in the US now, they have evolved to build this center. There are 2, there's a 3rd one under construction. And in fact, 80% of all ex vivo lung perfusions in the United States today is being done in the centralized facility and not by the individual centers. And again, the surgeons doing the transplant, they get all remote access. And this is just to have an idea. The 2024 is not updated here, but they had about 250 cases done this year. And you can see this exponential growth of lungs being sent to these facilities for treatment. So I think that's something important to consider as well. Now, just to finalize here, why a program volume matters. I think the increased experience from a surgical team, anesthesia, critical care, pulmonology, ID, and other associated services, nurses, and so on are very important. It brings that question whether practice makes a perfect concept, or practice makes perfect as a concept. But I would like to also highlight here that we have seen programs that have grown too fast to have very bad outcomes. And this happens, again, more commonly in the United States when they have a program which is very small, and then they hire a very aggressive surgeon. The surgeon arrives there and then goes from 30 transplants a year to 100 transplants a year. but the structure of the hospital and all the other services, they're not prepared for that. And then what will happen is you have really bad outcomes for a couple of years, and they will shut down your program. So the growth has to be like, gradual, like a stair. And you have to build and create capacity as you go, and not have this big jump. It doesn't work. Now, I think it's also important to highlight that not only the index procedure is important, but better management and rescue of patients that develop complications. A high volume center have no issue at all rescuing a patient on ECMO. They have very low rates of complications, for example, for ECMO, whereas a center that does like 5 ECMOs a year, they'll have a lot of complications from that. But again, we know small centers can also have good outcomes, as discussed previously. And I think when you talk about outcomes, we need to have an inclusive approach, meaning patients with end-stage lung diseases in the community, both the listed one and non-listed, should be included in that overall outcome picture. As I mentioned, it's not only about the patients you do the transplant, it's also about the patients that are waiting for transplant, or patients that cannot even get into the list because the pulmonology team do not refer them because they know the patients will die before a transplant. Because again, not having enough volume to sustain that population. So all those things, I think, should be placed in consideration. And this is what happens in our program in October 2024. We had 31 transplants in 31 days. And you can't, I think, argue, that this was more routine than doing a lobectomy, in that month for our hospital. And so it does become safer, and the experience that the teams acquire is tremendous. So I think that's very important. But I also would like to mention, and this is our group, the only way we do, again, 210, 215 lung transplants a year is because we have a big group of surgeons and pulmonologists and so on and so forth. I do think, in my experience, the maximum number of transplants that a single surgeon should do is about 50 a year. I think if you go more than that, you may be burned out at the end of the day, especially if you also have other type of practice as thoracic surgery or cardiac surgery. Of course, now with most of the transplants being done daytime, this changed a little bit, but still I think the about 4 transplants a month to a single surgeon seems to be a maximum, in my view, from both safety of the patients and also safety of the surgeon's health. So I'll finish here, and I'm happy for the discussion. Thank you.
Yeah, thank you, Marcel, for pointing out the advantages of high volume. I think you both mentioned important quality parameters to look at, and Marcel, you mentioned the programs might be shut down due to quality indicators like 1-year mortality. So when moving on to lung cancer surgery, which is certainly practiced in a much more also diverse range of hospitals, the approach is very different in individual countries. So I'm looking forward to Hake's presentation now on the European perspective, how volume in lung cancer surgery is managed.
I hope I can open up the file now. Seems to work. Thank you very much for the invitation, Clemens, to talk here on this topic. But I need to jump.
Okay, you're on slide 15. So
I'm jumping forward. Sorry. So I'm talking about surgical volume and outcome in lung cancer surgery. I hope you can see the slides and also hear me for this talk. So these are my disclosures. There will never be a single measure of quality, and attempts to improve quality using one metric may have unintended consequences. This statement in the article of Farja and Detterbeck on what is quality and can we define it in lung cancer was published in 2015 and points out different aspects of difficulties to define and to measure and control quality of care for patients with non-small cell lung cancer. The key question is really, how do we define quality in oncologic surgery, as we just heard also in other types of surgery? Usually, annual hospital volume is used as a proxy for measuring and improving surgical quality. An article published by Birkenmeier and colleagues in the New England Journal of Medicine in 2002, it's years ago, but was very good, and he investigated mortality for different solid cancers following surgery according to hospital volume. They could show that mortality decreases with a higher surgical volume, and this was most pronounced for rather complex surgeries, such as esophagectomies, as shown here, or pancreatic resections, and highlighted in the red bars, showing that there is a decrease in problems and mortality if the amount of surgery is higher than in smaller centers. Now, coming to non-small cell lung cancer, Lichtenborg analyzed 134,000 patients with non-small cell lung cancer diagnosed in England between 2004 and 2008, of whom almost 13,000, that's roughly 10%, underwent surgical resection. There was an increased survival in hospitals performing more than 150 surgical resections shown here, and they used different models to calculate this. Dr. Baum from our clinic analyzed nationwide the effect of high procedure volume in Germany for lung cancer surgery, analyzing patients operated on for non-small cell lung cancer between 2014 and 2017, including almost 122,000 patients, of whom 36,000, that's roughly 30%, underwent anatomical resection. In-house mortality ranged from 25% in small centers with less than 7 cases per year to less than 2.5% in high volume centers. There's an article that was published from the Taiwanese group by Lien that was published in 2007, and that's upon data from 2001 through 2004 from the National Health Insurance Research Database in Taiwan. In his article, he looked upon about 5,000 patients with pulmonary resections for lung or bronchial tumors that were treated by 377 surgeons in 79 hospitals. Patients treated by low-volume surgeons with less than 47 lung resections per year had significantly higher in-hospital mortality rates than those treated by medium or high-volume surgeons, as you can see up here. However, interestingly, in his research, there was no hospital case volume alone that was not significant predictor of hospital inpatient mortality for lung cancer resections in the Taiwanese analysis. A meta-analysis shown here on the effects of hospital volume of lung resections on mortality and survival of articles published between 1990 and 2011 was conducted by von Mayenfeld with 19 relevant studies that were identified. Studies were pretty heterogeneous, especially in defining volume categories. The pooled estimated effect size was significant in favor of high volume hospitals regarding postoperative mortality, as you can see here. To investigate variations in treatment in Europe and to compare those to the US, Philip Baum from our department performed a large-scale international retrospective cohort study analyzing data from 6 European national population-based cancer registries, including those from, as you can see here, Belgium, Denmark, the Netherlands, Slovenia, Estonia, Germany, and as a comparison, also the United States, with use of the USCR database. Unfortunately, data from other European countries such as France or Italy or England were not available for this study. A total of 428,000 patients from 7 national cancer registries diagnosed with non-small cell lung cancer between 2010 and 15 were included into this analysis. While the age standardized stage distribution of non-small cell lung cancer, as you can see here, with differences for stage 4 depicted in orange, stage 3 in yellow, stage 2 in blue, and stage green were homogeneously distributed amongst the different centers and the study period, we found a substantial difference in the primary treatment approach for stage 1 patients, and that is shown on this slide here. Estonia, interestingly shown here with a dark red line, had the highest surgical resection rate of almost 80% of the patients resected and the lowest radiation rate, as you can see down here. Whereas in the Netherlands, we found the highest rate of radiation therapy for those early stage lung cancers, as opposed to a very low resection rate seen on this side here. Now, volume, as we've just heard, is not the only factor determining hospital qualities. Other important factors may be the experience and training of surgical staff, the availability of the multidisciplinary team, training of the nursing staff, and other factors that have just been mentioned by the others. To evaluate whether there may be a better measure for quality than just volume on its own, we investigated risk standardized mortality rates in a nationwide cohort of almost 488,000 patients undergoing oncologic surgery from 2010 to 2018 in Germany. Risk standardized mortality rate is defined as ratio of predicted or observed to expected in-hospital mortality multiplied by the national unadjusted rate. To illustrate the problem when volume is the proxy, I've depicted 2 hospitals here, with one being green and the one being red, and I need to jump up. So in one hospital, you might have 20 patients with a mean age of 45 years and a very low comorbidity burden and a surgical mortality rate of 5%, whereas in a different hospital, again with 20 patients, the mean age of these might be a lot higher, with, for example, 85 years, a high comorbidity burden, and a surgical mortality rate of 15%. So to analyze the potential risk of standardized mortality rates and to define quality of surgery for non-small cell lung cancer, we used a nationwide cohort of almost 490,000 patients undergoing oncologic surgery from 2010 to 2018 in Germany for any 5 major cancer types, splitting the data into training cohort from 2010 to 2015 and a validation set for the patients registered from 2016 to 2018. The cutoffs for RSMR and the volume approach was established in a training set, and the outcomes then were calculated in a validation cohort between 2016 and 2018. 158,000 patients were treated in 974 hospitals, and at least 50% of the high-volume hospitals were not ranked in the low mortality group according to the RSMR grouping. Now, if you look at this slide here, by analyzing the overlap of both the volume shown down here with low volume centers, medium volume centers, and high volume centers, and the low, medium, or high risk for risk standardized mortality rates, then you can see that in centers with high volume that were not very abundant in Germany, there are a higher amount of low risk standardized mortality rates, but also you find patients up here with high risk of mortality in this cohort of patients in high volume centers. Therefore, for institutions with very low volumes, it is difficult to reach high performance, as you can see here. There is in the low volume centers, we didn't find low risk standardized mortality rates. But more volumes, as you can see on the right-hand side here, does not necessarily translate into a better outcome. And we heard that also just right now for smaller centers performing lung transplantations. Now, when we simulated a market closure for all low-performing hospitals, assuming that patients who were moved would achieve the mortality rates observed in corresponding high-performing departments, we calculated the number of patients who would need to change hospitals to save one single life. And in a risk standardized mortality rate-based approach, shown here for lung cancer patients, 33 lung cancer patients would need to change the hospital to save one life compared to 48 patients in the volume approach group. So to conclude, this volume by itself identifies low performers well, but does not really identify high performers. So the more, as I try to show, is not necessarily the better. And risk stratified mortality rates are more effective than volume in recognition of patients that may be moved to different hospitals to save lives. Quality, for no question, is a multidimensional construct, and that is true for patients operated on for lung cancer or that got lung transplantation being performed. With this, I thank you very much for your attention, and I am happy for any questions.
Yeah, Hake, thank you very much for this nice overview. And now we're coming to Moishe Liberman, who is also working, as we've heard before from Marcelo, in a single-payer healthcare system in Canada with a lot of regionalization, and we're looking forward to hearing the North American perspective on volume in lung cancer surgery.
Thank you very much. Can you hear me?
Yes, we can hear you perfectly fine.
Wonderful. Thanks for the invitation. Really a pleasure to be with all of you today, and thanks for the opportunity to present. I'm going to present on the North American perspective on volume in lung cancer surgery. These are my disclosures. None of these disclosures are related to what I'm going to speak about today. The only disclosure I'll make is that I'm really not a world expert in volume in lung cancer surgery. So I'll try and do my best to give you an overview of my understanding and the North American perspective. So, sorry about that. So just to put you in context, I think most people on the line are probably in Europe. North America, at least for now, this may change January 20th, is separated into two countries, the US and Canada. However, we may become the 51st state as the new president takes effect on the 20th of this month. Canada is a very, very large country with very few people. So you can see the big yellow area on the map. There's 41 million people in 2024 in Canada, as opposed to the United States, which is a smaller country, but is inhabited by 335 million people, so much more populous. In Canada, thoracic surgery training in general requires 5 years of general surgery. Following general surgery, fellows of the Royal College of Physicians and Surgeons of Canada do a 2-year fellowship in general thoracic surgery, which includes a little bit of cardiac surgery, a minimum of 3 months. Some places do more, but the minimum is 3 months. And the cardiac surgeons in Canada really do not perform lung surgery. Maybe 10, 15 years ago, there was a few, but I think today, and I could be wrong, there is no cardiac surgeons that are doing lung surgery in Canada. And there also is very few general surgeons doing lung surgery in Canada, whereas years ago, it was split between general and thoracic surgeons. But as more and more fellows and residents got trained in thoracic surgery, there has been less and less general surgeons. I think in Quebec, which is the province that I am in, less than 10% of lung surgery is done by general surgeons, and probably within 15 years, that will be gone. In the United States, residents are trained in the American Board of Thoracic Surgery. That board is a cardiothoracic board. You can either enter it by doing a 5-year general surgery program and then entering a 2 to 3 year fellowship in cardiothoracic surgery, or you can do a direct program, which is, I think they call a 4-2, where they do 2 years of sort of general surgery rotations and then 4 years of general thoracic with some cardiac. However, in the US, there is a lot more general surgeons doing lung surgery than in Canada, and I think as well as in Europe. And a lot of cardiac surgeons perform a hybrid practice where they do heart surgery and lung surgery, esophageal as well, but that's not the topic today. And that's mostly in smaller private hospitals as opposed to in the academic medical centers where mostly general thoracic surgeons are doing the lung surgery. This is a paper by Berkmeyer's group looking at the percentage of lung surgery being done by the different types of surgery in the United States. And you can see it's about a split, about 30% each between cardiothoracic, general surgeons, and thoracic or general thoracic surgeons. Most of the really good literature on regionalization and volume outcomes in lung comes from Europe. As you guys know, in Canada and especially in the US, there's very, very little data and publications on this subject. And that is for a multitude of reasons, but I think a lot of it is because it's not really changeable. And so people are less interested in just reporting things that can't be changed. And so I'll try and present here the papers that are North American related, and I'll leave the European papers out as they were well presented by Hake just before. When you look at surgeon specialty and operative mortality, this is the United States, you can see that the adjusted mortality rates for lung surgery, 7.6% for general surgeons, and then 5.6 and 5.8% for non-cardiac and cardiothoracic surgeons. When you look at high volume surgeons, and I think for us in Canada and you in Europe, this number seems a bit odd, but they consider a high volume surgeon a surgeon that does more than 20 lung resections per year. I think most of us on this call would consider more than 20 lung resections per month to be a medium volume surgeon. So this is what they consider high volume. And you can see that the mortality was still higher in general surgeons in these high volume surgical resection. And if you look at high volume hospitals, which again, I don't agree with as a true number, they say if your hospital does more than 45 lung resections a year, you're a high volume hospital. And here you can see also that the general surgeons had a higher mortality. This paper in New England Journal from 2001 looked at patients that were 65 years and older, again in the USA, stage 1, 2, or 3A non-small cell lung cancer. They used SEER data, and they had a total of 2,118 patients over 76 hospitals. You can see how low the volumes are per hospital when you're talking about 2,000 patients in 76 hospitals. And you can see as the procedure volume increases, the 30-day survival increases, the 2-year survival increases, the overall survival increases. And this is the same whether you're in a teaching hospital or a non-teaching hospital. Again, the highest volume hospitals in this sample were only performing between 67 and 100 procedures per year, and that's only 2 hospitals. The majority of hospitals, if you look here, I don't know if you see my pointer, but you see 34 of the hospitals were performing between 1 and 8 lung resections per year, which I think is a very, very low number. When you look at outcomes in that same cohort, you can see that the length of stay was improved as your volume went up, complications were reduced, 5-year survival was better. And so obviously we already know that volume has an effect on outcome and specifically for lung cancer or for larger complex operations. And don't forget, all of these numbers and papers that I'm showing you are in the pre-induction era. So the surgery was easier, the risks were less, there was less complications, there was less sleeve resections, pneumonectomy was done in the majority of patients with hilar tumors as opposed to sleeves. And as we all know on this call, operating after chemo-immuno is not the same as operating on patients who are treatment immune or naive, sorry. And again, this is just to illustrate that the lowest volume hospitals had the highest mortality, and the higher volume hospitals linearly had a improved survival at 5 years. When you look at paper here from 2022, minimum volume standards for surgical care of early stage lung cancer, and this is a cost effectiveness analysis also from the US. They are using a radar plot. I wasn't familiar with this type of plot, but I looked over it this weekend. And just to show you, they're showing here that high volume surgeons are red, so the red line here, and low volume surgeons are the blue line here. And as you can see, the red line or the higher volume surgeons for lung cancer specifically have lower hospital stays, less readmissions, less cost for the institution and for the payer, and also improved overall and disease-free survival. However, there's not a huge difference, at least in this SEER database study, in survival in patients who are operated by high volume versus low volume surgeons. Again, we're not talking about high volume versus low volume hospitals, which is probably more important than the surgeon because of the multidisciplinarity of care. But you can see that most of the outcomes did favor high volume surgeons. This paper I won't go over because Hake already showed it, and I think he explained it probably better than I would. But in brief, it's just showing a meta-analysis where almost every study shows that hospital mortality is reduced as surgeon volume and surgeon specialty is increased in terms of lung cancer. And this is also a US study looking at patients traveling from far to go to a higher volume hospital. And you can see that patients that were treated in local hospitals in blue had lower survival than those that had to travel a distance to get to the higher volume centers. Of course, that comes with the drawback of difficulty for patients and costs and for families. But in terms of survival, you're better to travel a little further to get to the bigger or more volume centric hospital than to your local hospital. This is a study that we did here in Montreal using the Quebec healthcare system data. We published this in 2022, and we are a single payer system in Quebec and in Canada. Every province pays for all care in terms of lung cancer and for almost all non-cosmetic and very elective surgery. So every patient in our province is paid for by the Quebec healthcare system. This is a retrospective cohort study where we used administrative provincial population-based data, and we looked at all adults with non-small cell lung cancer surgery who underwent either lobectomy or pneumonectomy between 2008 and 2017. And again, this was before the era of massive pre-op induction therapy. We split the hospitals based on low, medium, and high volume. How we chose those numbers were based on where the numbers plotted out. We didn't arbitrarily choose the numbers, but there was, about a third of the hospitals that were in the low volume or less than 50 patients. There was about a third of the hospitals that were between 50 and 20 patients. And then there was the high volume hospitals, which had more than 200 procedures per year. And you can see here, we looked at 30, 90-day, and 1-year survival. We looked at length of stay, ICU readmissions to hospital, and we tried to use logistic regression to make the patients more similar. And so we started with 62,000 patients. We finished with 10,440 patients after we excluded patients that had missing data, that had chemoradiation therapy, that had a sleeve resection, that were small cells or carcinoids and other things. And here you can see the patient characteristics. So you can see that for pneumonectomy, and we split pneumonectomy from lobectomy. Again, this was before sleeve resection was a very dominant part of the practice in this province. And don't forget, years ago, the majority of surgery before general thoracic surgeons took over, the volume was being done by general and cardiac surgeons. So pneumonectomy was much more prevalent for hilar tumors. You could see that low volume hospitals overall did 237 pneumonectomies, not per hospital, but overall in the system. But the most interesting is the median annual volume. So the low volume hospitals were doing about 4 pneumonectomies a year, whereas the high volume hospitals were doing about 46 pneumonectomies a year, which is interesting if you think about it, because today, we're one of those high volume hospitals and we do like maybe 1 or 2 pneumonectomies a year, but I guess in the old days, there was a lot more being done. And when you look at lobectomies, low volume hospital median volume was 23, medium volume hospitals 71, and high volume hospitals 198. And when you look at length of stay, there was no difference in pneumonectomy between low volume and high volume hospitals. And lobectomy did have a lower trend towards length of stay, but really not a real difference in length of stay. Again, this is before ERAS and all of these pushes to get patients out of the hospital early and pull tubes early and send patients home with Heimlichs and things like that. And looking at pneumonectomies in terms of mortality, you can see that low volume hospitals had a much higher 90-day mortality than medium and high volume hospitals, and at 30 and at 90 days. And when you looked at overall mortality at 1 year, you can see that high volume hospitals had a much lower 1 year overall mortality. And if you look at mortality at the end of study, 57% of patients who had pneumonectomies at the low volume hospitals did pass away before the end of the study. And that's probably due to poor patient selection and poor staging, not due to bad surgery, because most of those patients did leave the hospital. When we look at the same numbers, but for lobectomy as opposed to pneumonectomy, which I think is more interesting in today's day and age, you can see low volume hospital 90-day mortality was 3.6%, and the high volume hospitals was 2.1%. So there was a significant decrease. There was also a decrease between medium volume and low volume hospitals in terms of 90-day mortality and 30 days as well. And overall mortality at 365 days, 1 year mortality for low volume hospitals was 10% versus 5% for high volume hospitals, just showing that in our regionalized single payer system, volume does make a large difference. And due to this study, we have shut down many low volume hospitals in our province. And currently there is, I think, 8 hospitals, as opposed to 30 hospitals when we had done this study, that are doing lung surgery, which I think is to the betterment of the patients. So again, North America is a big grab bag of different sort of ways of treating patients with lung cancer. In the Canadian system, most of the centers are regionalized. Almost all hospitals are doing large or medium volumes today. Almost all surgeons are trained in general thoracic surgery and perform only lung, esophageal, mediastinal surgery. In the United States, there is a grab bag of general surgeons, cardiac surgeons, and general thoracic surgeons, depending on if you're in a low volume or high volume hospital. And most of the academic centers, again, are using general thoracic surgeons, but most hospitals in the US are not academic medical centers, and there's still a lot of cardiac and general surgeons who do an aortic valve in the morning, a cabbage in the afternoon, and a wedge at the end of the day. And I think that is something that's probably not going to change in the near future, because there's a lot of different aspects that make that reality. And I think you guys got it right in Europe, and we're trying to become more like you in Canada. So thanks for your time. I appreciate the opportunity to present and look forward to the discussion.
Yeah, thank you, Moishe, for this nice overview on the North American perspective. So we're a little over time, but I think we take time for one question if there's any burning issues from the audience. So maybe in the meantime, I think we've heard from all of you that volume is an important parameter, but definitely not the only important issue to look at when judging quality of programs and deciding who should perform a certain type of surgery or not. So maybe can each of you give a brief summary based on the available literature and what you presented? What would be ideal parameters to look at when judging whether a program is a good program, and probably when deciding who should perform lung transplantation or lung cancer surgery and who should not? Maybe Alessandro, can you start?
Yeah, thank you, Clemens. I think the presentation were really productive, and thank you again for allowing to participate. I think the overall judgment should really stand on the complete package of what the institution is able to provide. So not just the numbers, but again, all the processes. And Marcelo mentioned the pre-op as well, the ability to provide transplantation all the patients who require it. So again, I would rather try to build a scoring system that includes all the processes of care and is able to distinguish between institutions and programs that can perform despite the numbers and institutions that cannot perform despite the lower high numbers.
Marcelo?
Yeah, I think I agree with that. I think we should look at, kind of an intention to treat type analysis by the time you are listed, how you do, not only after transplant. And I think that small programs, they can have very good outcomes. There is just a lot more variability in the outcomes when you take a cohort of small programs. And I think that's especially important, in some scenarios, like I see, again, in some US cities where you have 5, 6, 7 lung transplants in one city. I think centralizing would be important in that context to decrease that variability. But I agree, small programs can have very good outcomes. Large programs in general have more consistent outcomes.
Okay, thank you. So Hauke, what would be your set of parameters you look at for lung cancer surgery?
Well, as I try to show, its volume is one proxy that you can use, and it's possibly not a bad one, but it's by far not the only one. And there are many aspects that are important when it comes to a good treatment of a patient. That starts with the indication, then with the surgery, and then a treatment following surgery. So it's always a huge, big team that needs to somehow be looked at and upon, and many aspects of quality that have to be checked. I think risk standardized mortality, as I showed, is one possibility, probably to better judge patients and treatment of patients. But volume, at least, is kind of an easy one and has just been implemented in Germany, with minimum volumes being implemented in the beginning of this year out of good reasons, as we've seen in the data. So there are other measures too, like in Germany, Deutsche Krebsgesellschaft, that are important to look at all the other things that I've just mentioned, and to make sure that quality is not only talking about surgical quality, but of course also quality in all the other aspects that deal with the patient.
Okay, thank you. And Moishe?
Yeah, I agree with what everyone said, and especially in terms of lung cancer, what Hake was mentioning. For lung transplantation, I think we've all agreed over forever that it's super complex and requires a lot of resources, and of course you need a high volume. And I think that lung cancer 15 or 20 years ago was pretty easy. You had a CT scan, there was a tumor, you sent it to the surgeon, they took it out. Lung cancer today is very complicated, and it requires a huge team of people, sort of like lung transplantation always did, where you need expert medical oncologists, you need expert radiation oncologists, you need specific pathologists who know how to do molecular diagnostics, you need interventional endoscopists who can do biopsies and staging and ablation. And now there's robotics and sublobar resections, and there's all of these different technologies that we didn't have 10 or 15 years ago. So I think that the regionalization has become, or the volume criteria has become even more important, because you need to not just do a number as the other presenters have talked about, but you need to have all of those people in place to have the multidisciplinary committees and the meetings and make the best care for the patient. Because it's not as like in the old days where it was, you have a cancer, let's remove it. There's so many choices and so many options, not only in the treatment, but also in the staging and the diagnostics. It's an exciting time to be a lung cancer surgeon, and I think it's just going to get more and more exciting, but it gets more and more complex. So we can't allow people who do occasional lung surgery to do that. And it's not the surgeon, it's the hospital and the team.
Yeah, I think that's an excellent final word. I think we all agree that the interdisciplinarity and the setting is a very important issue for thoracic surgery. So I would really like to thank all of you for the excellent presentations. Marcelo for joining in even from holiday. And I would also like to invite you to the next ESDS webinar, which is actually also focused on the interdisciplinary collaboration. It's about interdisciplinary management of lung transplant recipient, and it's in conjunction with the ERS taking place on February 10th. And I would very much like to welcome you there as well. Thanks for today, and enjoy the rest of your evening.
Thank you.
Bye-bye.
Clemens, thanks.
Thank you very much.